Greetings and welcome to this video on antibiotic series where we discuss about drugs that are active against the MRSA organisms or the highest resistant gram positive organisms such as MRSA, Enterococcus faecium and all these things. So up till now we have discussed about carbapenems, beta-lactams, BLBLIs, as macrolides, aminoglycosides. If you have not watched all those videos, you can go back and watch all those modules. Now in this video, we'll specifically discuss about glycopeptides and lipopeptides. So MRSA coverage is not a hypothesis, not a reflex. It is an hypothesis. So you have to first detect MRSA, then go for such antibiotics. Otherwise, there is no point in giving such antibiotics because other organisms respond better to other beta lactams rather than going for an vancomycin or a linezolid. So if you're new to this channel, subscribe. This is completely for educational purposes and for practicing physicians. This is medicine beyond Harrison's. Let's get started. So IDSA says, can MRSA be present? It's not the question. It is the main question is MRSA probable enough to justify harm? That is what is the question. So MRSA can be present. That is not an issue. It can be a colonizer. It can be present in the nasal mucosa as a carrier state. But whether it causes harm, that is what is the right question. And if it causes harm, then choosing the antibiotic for that illness is what is the real challenge. So vancomycin toxicity is real. So just don't go for vancomycin for all MRSA organisms wherever you detect in the lungs or in the urinary tract, wherever it is. It is a highly toxic molecule for the kidneys. So it also overuse of vancomycin leads to vancomycin resistant Staphylococcus aureus. And most sepsis is not MRSA. So whenever you find a sepsis, don't suspect MRSA unless there is a gram-positive cocci growth or when there is a Staphylococcus aureus growth. So vancomycin, we specifically discuss about few drugs in this module where we discuss about vancomycin and linezolid, daptomycin. There is other drugs that are used for MRSA, such as teicoplanin, which we'll discuss separately. So vancomycin specifically inhibits cell wall synthesis. It has a different site of action other than the beta-lactam group that where it acts. It is a time-dependent killing. So the duration of time it remains above the trough or inside the area under the curve it exhibits its action. So it is a very slow bactericidal activity. So prefer a beta lactam in case of it whenever a beta lactam is sensitive and do not go for a vancomycin. So it specifically covers only these groups. So MRSA, resistant streptococcus, enterococcus, and Clostridium difficile that were given as a oral tablet formulation, not as an IV drug. So it completely misses out on coverage for gram negatives, anaerobes, and vancomycin resistant enterococcus. So for all these groups, you should go for one step higher, maybe a teicoplanin. For gram negatives, better go for a penicillin. For anaerobes, go for a drug that covers anaerobes like clindamycin, metronidazole, or carbapenem that can cover anaerobes also. So the most important Vanco concept is that troughs, the concept that we used previously. The trough is the amount of drug needed to reach specific concentration to inhibit the bacterial growth. The trough concept is now dead. It's not used now. Now the concept used is area under the curve or the minimum inhibitory concentration. That is the goal. The IDSA target is 400 to 600 micrograms. It be remained above the inside the area under the curve or the minimum inhibitory concentration to kill the bacteria. So more than 600 leads to toxicity. Less than 400 leads to underactivity. So this is a very important pharmacokinetic thing that we need to achieve on giving a vancomycin. So why overdosing leads to nephrotoxicity and poor outcome. So this is the Troughs concept are now used nowadays. So now the loading dose is 20 to 30 mg per kg. Even in acute kidney injury, go for this loading dose to reach the adequate area under the curve concentration. So this often fails in case of an obese patient who is underloaded. When there is augmented renal clearance in a young male or a young female, there is subtherapeutic exposure. MIC creep. MIC is usually 2. When there is MIC creep, the vancomycin can fail. Lung infection. Again, vancomycin is a poor penetrator of the lung tissue, especially the alveolus. When there is a pneumonia due to MRSA, prefer linezolid other instead of vancomycin. The failure is not always equal to resistance. Often it is a pharmacokinetic failure. So you give the dose at an adequate duration and adequate concentration and adequate dosage in the right timings, then it will work. Rather than most of the times, vancomycin fails because of pharmacokinetic failure. So daptomycin, it is a rapid killer. It is compared to vancomycin. In contrast, this is a rapid bactericidal drug. It is concentration dependent killing. So vancomycin was a time dependent killer. This is a concentration dependent killing. Excellent for bloodstream infections. Covers MRSA and vancomycin resistant enterococcus also. The problem is that it's just again very poor penetrator of lung tissue. It is also inactivated by pulmonary surfactant. So does not work in case of pneumonia. So this cannot be used in case of pneumonia. So linezolid, so L for L, you can remember L for the lung specialist, linezolid. Excellent lung tissue penetration. It is 100% oral bioavailability compared to IV also. So preferred for MRSA, pneumonia, and vancomycin resistant enterococcus. The thing is, it is only bactericide, static. So it cannot be used commonly in bacteremia. So thrombocytopenia can occur for more than 7 to 10 days used to do bone marrow suppression. There's high risk of serotonin syndrome and neuropathy in case of long-term usage. So, decision matrix, when you suspect a vancomycin resistant enterococci or an MRSA, if it is a bacteremia, always go for vancomycin or daptomycin. If it's ammonia, go for linezolid preferably. If not, linezolid not or contraindicated, go for vancomycin. If it is skin and soft tissue infection, it is severe, then go for vancomycin. Nowadays, we also prefer going for ticopranin. So, studies recommend going with vancomycin. In case of alternate with less toxicity, you can go for ticopranin also. The vancomycin resistant enterococcus bacteremia, go for daptomycin. So in case of renal failure, you can go for linezolid. So these are the use cases of current use case of glycopeptides and linkopeptides. This is daptomycin, linezolid, and vancomycin. So this table you have to master it. Pneumonia, always remember linezolid. Skin and soft tissue, vancomycin or ticoplanin. Bacteremia, it is daptomycin or vancomycin. So for renal failure, go for linezolid. So start empirically if you suspect a septic shock plus pneumonia, prior MRSA colonization in the patient with the culture positive MRSA in the past, ICU with high MRSA prevalences and intubating devices, skin source, if it is all these are there, then directly go for an vancomycin empirically. Then after obtaining culture, you can continue or stop. So stop if there is culture negative at 40 to 72 hours and MRSA clean is negative and clinical syndrome is inconsistent for MRSA. In all these cases, immediately you can stop vancomycin. So early de-escalation is a quality marker of any hospital or any ICU setup where you have to de-escalate as and when appropriate. So for example, you have a gram-negative organism which is an E. coli bacteremia, no MRSA risk factors, and you can no need to give any vancomycin, linezolid, daptomycin. In this use case, just go for a beta-lactam. So this resistant strain is expertise and not negligence. So you must know when to use these drugs. These are drugs especially for MRSA endocarditis, then for this vancomycin resistant enterococcus and other bloodstream infection of streptococcus and skin and soft tissue infection only, and not for other gram-negative organism infections. So vancomycin should be earned by the patient, whether they it should be earned by the bacteria. It is a very probably a costly drug or rich drug for the bacteria, such that in MRSA only you must need to use vancomycin. It can't be just assumed. So why does vancomycin have the worst outcomes than beta-lactams in MSSA and bacteremia, even when MIC are favorable? Why? In MSSA, even now we use cefazolin, flucloxacillin, dicloxacillin for treatment of MSSA and not vancomycin, even if vancomycin is sensitive. So why? Because it is a very slow bactericidal drug. So in case of cefazolin or flucloxacillin, the bacteria gets eradicated so fast, and there will be a higher, lower mortality and morbidity in case of usage of cefazolin and other beta lactams instead of a vancomycin for MSSA. Vancomycin is only for MRSA. So you must, before using a drug, you must know the mechanism and kill kinetics. So hope you understood about the vancomycin, daptomycin, linezolid, and the specific use cases. We'll go deep into each of these antibiotics in the upcoming modules. Thank you for watching.